All right, hey everybody, welcome to our series, All You Need to Know. Today we're going to be talking about syncope, okay? When I started to think about our next topics for this series, I really wanted to focus on the workup of syncope, or more specifically, things not to order. But the further along I got in preparing for that session, I realized that we needed some more context. So in order to stay true to the spirit of these videos and to keep them short and sweet, I decided to break it down into two different parts. So today we're going to be talking about part one, which is determining the etiology and assessing risk in syncope patients. And then part two, we'll talk about the workup. Okay? As you can see here, I'm not really going to discuss management of syncope. And the reason for that is if you understand the etiology and you understand how to work it up, the management's pretty intuitive. Okay? All right, so I primarily am going to be using the European Society of Cardiology guidelines for these videos. It's a great document if you want to take a chance to reference it. The American College of Cardiology also has some good guidelines as well. They're mostly the same, a couple of minor differences. But the ESC guidelines are a little bit newer and, in my opinion, a little bit easier to digest. Okay, so the first thing you need to know about syncope is the actual definition of syncope. So syncope is the transient loss of consciousness due to global cerebral hypoperfusion. Now I've emphasized each word and each phrase because these words and phrases are key in differentiating syncope from other similar events, right? Other things that kind of add to this differentiation are these other characteristics. So it's got to be rapid in onset, short duration, and spontaneous complete recovery. Okay, if an event doesn't fit these descriptions to a T, it's not syncope. Okay, plenty of things can have several of these components, but unless it has all of them, it's not syncope. Okay. Now, the second thing you need to know about syncope are the different types or the causes of syncope. So syncope is typically categorized into these three domains. It's either reflex syncope, or what we call basal vagal syncope, syncope due to orthostatic hypotension, or cardiac syncope. Okay. Now we're going to talk more about risk here soon, but in general, most cases of reflex syncope are low risk, and most cases of syncope due to orthostatic hypotension are low risk, whereas most cases of cardiac syncope are considered higher risk. All right, now reflex syncope involves a fairly complex pathophysiology. In short, though, it occurs due to a neurological response or reflex that occurs inappropriately to an external stimulus. Okay, and that response results in either vasodilation or a slowed heart rate, both of which can result in cerebral hypoperfusion. So basal vagal syncope is a term often used interchangeably with reflex syncope, and that makes sense because that term kind of directly implies the pathology. Vaso is referring to the cardiovascular system, and vagal is referring to the vagal nerve, which, again, this occurs because the vagal nerve is abnormally responding to an external stimuli that results in vasodilation or bradycardia. Now, most commonly, this external stimuli that we're having an abnormal neurological reflex to is emotional, okay? Such as when somebody syncopizes at the sight of blood, or when they get really upset. It can also be positional in nature. The classic story is somebody who's been standing too long in church singing their hymns, and they syncopize. There's other types of reflex syncope. Situational syncope falls under this category. That can occur with urination, coughing, sneezing, laughing, blowing on an instrument too hard, those kinds of things. And then lastly, carotid sinus syndrome is a type of reflex syncope. Now, this reflex occurs when there's pressure applied to the sympathetic ganglion sitting above the carotid bulb. Okay, this can sometimes happen in men who are wearing tight collars or a tie or when they're shaving. But I want to be clear, this is not due to carotid artery occlusion. Okay, it's not due to reduced blood flow because you've got a kink in the carotid artery or blockage or something. This is just stimulation of the nerves that sit within the carotid. Okay, we'll talk more about carotid artery disease soon, but this is not this is not pathology within the vesicle itself. All right. Now, we all know about orthostatic hypotension, but this is probably the most common cause of syncope in our patients, so I want to spend some time talking about it. Most commonly, this is going to be drug-induced. Of course, volume depletion can do this as well. And it could be as simple as, mild dehydration to severe anemia from whatever cause. There's lots of different causes of volume depletion resulting in syncope. And then lastly, autonomic failure can occur in primary neurological syndromes such as Parkinson's disease or multiple systems atrophy, or it can be secondary to something like diabetes or amyloid. Either way, there's going to be direct nerve damage of the vagal nerve or some of the nerves within the autonomic nervous system, which of course, like I've said, controls blood pressure and heart rate. Our last category of syncope is cardiac syncope. Okay. Now, arrhythmia-induced syncope can be due to bradycardia or bradyarrhythmias or tachyarrhythmias, and both of these result in cerebral hypoperfusion, but they occur by different physiologic mechanisms, right? So in tachyarrhythmias, there is a decrease in end diastolic volume because there's not enough time for the left ventricle to fill with blood, and due to that decreased volume, there's less blood being pumped to the brain. On the other hand, in bradyarrhythmias, you have a normal ejection fraction, but the hypoperfusion occurs because diastole lasts too long. Okay. Structural cardiac disease can lead to syncope. Classically, we're talking about aortic stenosis. Again, if you've got a tight opening in the aortic valve, you're going to have reduced blood flow to the brain, resulting in global cerebral hypoperfusion. Okay. And then when it comes to vessels, we include coronary artery disease within this category. We include PE, severe pulmonary hypertension, aortic dissection. All these things are within the category of cardiac syncope that deal with the great vessels. So as you can see, if you know this differential well, it should guide your questioning when you're taking your history, right? You got to understand what could cause it to make sure you're asking the right questions. But that leads me to my first take-home point, which is history taking is the single most important diagnostic tool at your disposal for syncope. Okay? Most of your syncope patients need no further workup beyond a good history and exam. Okay, and you can stop right there. The other thing that a good history can do is it's going to allow you to risk stratify, which is our next topic. So risk stratification is really important because it helps guide your workup, but it also conveys risk of a fatal event occurring within 30 days of presentation. So high-risk syncope comprises of a relatively small portion of all syncope cases. Well, let me say it this way. High-risk syncope is a small portion of our cases, the ones that get admitted to the hospital, and it comprises of an even smaller portion of all syncope patients, most of which we don't even see. Even conservative estimates say high-risk syncope is going to be less than 10% of all cases. So the question really is, how do we minimize the workup in these folks who fall in the low-risk and medium-risk categories and discharge them, or make sure we're minimizing their workup, while we are ensuring that these folks in the high-risk categories are getting the workup they need. Okay, so we know that risk stratification is essential. So how do we do that? Now, the easy way to risk stratify a syncope case is using the Canadian Syncope Risk Tool. Okay. Now, this is a great tool, and there's some great literature behind how this tool is validated, but I want to dig in a little bit deeper into the things that go into determining the score. All right, when it comes to assessing the risk of syncope, there are 4 domains that you need to consider. 1, the characteristics of the event itself. 2, the past medical history. 3, the physical exam. And 4, an EKG. Okay, so other than the EKG, as you can see, risk assessment really is all about the history and physical. Okay. And for the majority of your syncope cases, you can stop right here. Okay, take a good history, take a good physical, get the EKG, and that's going to be it for most of them. Okay, but let's talk a little bit about what types of questions we should be considering so we can help determine this risk. Now, when it comes to the event itself, these are the different components that are associated with low risk syncope. So if a patient tells you that it was associated with a prodrome, okay, so they felt lightheaded, or they had the sensation of warmth, or there was the event was preceded by nausea or sweating, it's probably going to fall into the low risk syncope category. If it occurs suddenly after an unexpected, unpleasant sight, sound, smell, or pain, it's probably low risk syncope. Patients who syncopize after prolonged standing, or if it's associated with meals, or if it's been triggered by a cough, defecation, micturition, all those things are usually low risk. If it occurs with head rotation or pressure on the carotid sinus, like we talked about, it's probably low risk. And of course, if it occurs positionally when you're changing positions from sitting to standing or lying to standing, it's probably a low risk event. Now, when it comes to, again, we're risk assessing based off of the event itself. If the patient tells you that the event was associated with chest pain or breathlessness, abdominal pain, headache, all those things are concerning. If it occurs during exertion, that's concerning. If it's associated with palpitations, that's concerning. Now, these other things, the ESC guidelines say that these are minor risk unless it's associated with structural heart disease or an abnormal EKG. That's probably true, but I think you should take these things seriously. So if it occurs with no prodrome, if it occurs while sitting, or if there's a strong family history of sudden cardiac death, those are the cases you probably need to take a little bit more seriously. Okay, what things can you ascertain from the past medical history that helps you risk stratify? So if a patient tells you they've been syncopizing for years, and this event is just like all the other events, it's probably low risk. If there's a known absence of structural heart disease in your past medical history, it's probably low risk. At the same time, if a patient has a history of severe structural or coronary disease, syncope in those patients are often high risk. Okay. All right, what about the physical exam? So if it's a normal exam, it's likely, it portends a low risk syncopal event. On the other side of the coin, if there's unexplained hypotension, if there's any concern for a GI bleed, if there's a presence of bradycardia, or if there's a new undiagnosed systolic murmur, all those things are concerning on exam. And then lastly, we're talking about the EKG. Of course, a normal EKG is low risk. All these things here are associated with higher risk syncope. Now, some of these things are a little nuanced and require a fellowship-trained electrophysiologist to kind of tease out. But as you look through them, these are things that we should be able to pick up, right? So this first one, we should be able to pick up acute ischemia. We should be able to pick up heart block. We should be able to pick up sinus bradycardia. Bundle branch blocks can be a little tricky, but we should be able to pick them up. Or a lot of these things that may be harder to pick up, the machine often is pretty reliable at it. Obviously, we should be able to pick up a VT. We should know Brugada pattern. We should be able to see the long QTC. So again, EKGs can be a little tricky, but most of the high risk major things are things that we should be able to pick up without being EP attending. Okay, so to recap, taking a good history along with characterizing the event and risk stratifying the event will help you determine the appropriate workup. And as you can see, you can really get a lot out of a little. Perform a good history, perform a good exam, and get an EKG, and you're most of the way there. Okay, so we're going to stop right here, and during our next video, we will talk about the workup. Okay.